start.
I'll leave these for them anyway here.
Here they come.
Let me give you something while you're here.
Oh, when you were up there.
Just for your
Locale, yeah. Very locale today, Steve.
We have two.
Incredible.
Yeah.
Oh, directories?
Just sign your name and take one?
Is that, yeah, I think that's what Glenn is
I
talking
ran
about.
into Teal in
That's his little
Barcelona.
Oh, really?
Yeah, just that meeting there,
And
and I
then
was on
don't forget to
vacation.
sign when she
He's
can.
doing serious business.
He was in a
But I
meeting?
ran into him in the airport, and I got off the wall. No, well, that was a year and a half ago.
Nice to have your meeting.
No, Taylor's late.
I ran into a high school problem.
First burn stuff. So you got the pumps running now, huh?
Is it snowing up there?
Yeah, they get snow
A lot
now.
of tourists.
Yeah, no, that's
Reasonable high.
It's so nice. Joan put together that.
Yeah.
Over here.
It has current emails too, which is really nice.
Yeah, no, exactly. It's a great idea. Say, who was it that asked that question at 8:05?
You're saying.
Do you think you're going to give that to me now?
Let me see.
Fair trade, right?
We need these two to judge the.
Will you be in your new place? You won't be in your new place.
What's that?
These are the.
The elevation things?
Oh, is that right?
It's
Our
different.
fellows will be here in 15 minutes. The car will start. We can't wait 15 minutes. We'll have to start your presentation.
Patient evaluation form.
Ah, fellas.
What does it say? Matt. Oh, those are for.
The fellow,
I
each
looked
fellow
it
has
up,
to have
I
a
looked it
patient.
up now.
Kind of a new
It
one.
makes it a lot easier for everyone.
Yes,
It
it's
was, that's a great idea.
lifetime
Yeah,
card.
it is, yeah. Yeah, in fact, there's a lot of information on that. I'll fill
Yeah, you know what, he's semester C.
Oh,
When I come through, I have a transcript.
from the University of Pittsburgh.
That's right. Greatest semester of my life. Oh, I know, I said
You're,
that. Life doesn't
where
get
were
any
you
better
at
than that. It was actually both when I was in the world. Are you familiar with that?
Uh-huh.
Yeah. So, we were all over although you couldn't go to the Suez Canal, so you had to go all the way around Africa to South America. Terrorists right our ship, so they went there.
Nice decision.
Let's go.
Let's go. I always wanted to see the South Africa.
Well, you know, those Arab countries, what was going on that ship is taboo. So they bring
Do you have any new body parts?
their target.
Wow. So when was
Body part? Ever give you trouble? Not this week.
Not this week.
That's good. Isn't it a shame we don't cover warranties? They blow up.
That's true. I'm
I guess.
That's like you still hope. So it's your payback is take care of my dog or trip.
That seems like a good job.
That's reasonable. Chuck? Coming down Mercer.
All right, well, I'm stalling a little bit here because the caterer is late and the fellows are late. But in fairness to Dr. Wenzel, who came all the way from Pittsburgh, I think we need to let her get started and give her presentation.
She's on time.
Come on.
Just a couple of things for those of you listening to me outside of this room. We just put together a directory with a lot of information about the allergy division, and for everybody outside of metropolitan Seattle, we'll put them in the mail. I sent them in the mail already to everybody who's not in Washington State. And for people who don't come here, particularly, we'll mail them out. Also, we're going to have a case presentation, assuming the fellows get here, in a second hour. So everybody who can stay, it's, I think, an interesting case. It's a patient of mine, so I'm sure you'll criticize the way I managed it. That's what I'm looking for.
Pediatric.
Yeah, immunodeficiency, as we talked about.
So today we've got a presentation by Dr. Wenzel, who's at the University of Pittsburgh, and very kindly has come out here to spend the morning with us. This is on asthma, heterogeneity, phenotypes, and endotypes. So it's all yours.
Well, thanks very much, Lou. It's certainly a pleasure to be here and talk about really a favorite subject of mine these days, which is asthma heterogeneity. And I think for many years we really thought of asthma as kind of a single disease, and I actually think that the pharmaceutical industry had something to do with that, perhaps, because we were very homogenous in our treatments. We had inhaled corticosteroids, you gave those to everyone. We had long-acting beta-agonists, you gave those to everyone. And I think this sort of lulled us into a little bit of a false sense of security that we were dealing with a single disease, when I actually don't think that we are. These are my current disclosures. I don't believe that any of them have any bearing on what I'm going to talk about today. So I like to start out when I talk about asthma heterogeneity by presenting just my initial approach to evaluation of difficult asthma. And this is actually from a paper that was in the ERJ by Helen Riddell and Robin Taylor that I think very nicely outlines the things that you should go through in your head when you see a patient with difficult asthma. And what do we mean by difficult asthma? We mean people who are requiring high-intensity treatment for their disease, and they either achieve good control only if they're on that high-intensity treatment, or they never achieve poor control. So you're left with this big pot of people. And I think it's important to do some initial clinical subtyping. This isn't really phenotyping, this is subtyping. And probably the most important of these, which we had a very long discussions on last night, actually, is determining, is it asthma? I can't tell you how many times someone comes to me with, quote, difficult asthma. They end up not having asthma. In fact, we actually presented an abstract at ATS where the first 150 patients that I saw at the University of Pittsburgh when I moved for asthma, and particularly difficult asthma, a third of them ended up not having asthma. And the vast majority were vocal cord dysfunction. That was clearly the common masquerader. And it's very sad. I mean, you have people on long-term oral steroids and Xolair, etc. They don't even have asthma. But anyway, I digress. And then the next phase is to say, okay, now they've got asthma. Are they potentially treatment responsive? Are there issues of compliance, persisting allergen exposure, etc.? Or do they fall into this group, which I think has a lot of overlap? So these are patients who have persistent comorbidities, they have persistent sinusitis, psychosocial issues, they're obese, or this group that is called treatment-resistant refractory asthma, where the disease itself is the driver of their difficult asthma. And like I said, I think there's a lot of overlap between these two categories, and it's really very hard to distinguish between them. That was a duplicate there. So anyway, so now you've determined that you've got someone who's got all these comorbidities, or they've got this refractory asthma. What do you do next? Well, I like to start by saying arthritis, anemia, and asthma. How are they all like? Well, they all start with A. But they're all very non-specific, general characteristics of disease. They describe swelling in the joints, low red blood cell numbers, reversible airway obstruction, and they really shed almost no light on what's the underlying pathobiology that caused these characteristics to develop. And if we just talk specifically about arthritis, certainly no self-respecting rheumatologist would ever ultimately diagnose a patient with arthritis. The natural history, genetics, inflammatory processes in response to therapy are going to be strikingly different depending upon which type of arthritis the patient has, i.e. understanding and treating rheumatoid arthritis is going to be vastly different from treating osteoarthritis. Now, we're not quite to that degree of differentiation with asthma yet. We're more in the category of phenotypes. And phenotypes, I think when you start talking about phenotypes, you have to explain what you're talking about. And the definition of a phenotype is the characteristics, with the emphasis on plural, of an organism which result from the interaction of the genes with the environment. It's not a single characteristic. It's not neutrophilic asthma. that's a phenotype. It has to be neutrophilic asthma in association with 5 other things that builds the phenotype of neutrophilic asthma. Now, we've been talking about phenotypes for, maybe 5 to 7 years, something like that, maybe a little longer. And I think in the last few years, there's been this concept emerging of endotyping. So endotyping is actually where you now start linking an underlying pathobiologic process to a phenotype. So you're not just describing characteristics, you're actually describing an underlying pathobiology. Now this is really, really in its infancy. We really do not have a good, strong understanding of endotypes yet. But I think we're headed in that direction. And I think there have been some very important papers that have been published over the last few years that are helping to point us in that direction. So I like to think of it as this umbrella term of asthma. Under the umbrella term, you've got, I think, the 3 hallmark characteristics of general asthma. So asthmatic-related symptoms, exacerbations, changes in lung function, all of those contribute to us describing that patient as asthma. But I think we're now starting to be able to sort out that there is a Th2-like inflammation in some individuals, and then in others, there's actually very little evidence for this type of inflammation. And I think that's our first step towards endotyping. We're, again, not there yet, but that's our first step. And under these general broad categories, I think we can now start to sub-endotype into an early onset allergic asthma, a late onset eosinophilic asthma, an obese asthma, and maybe a neutrophilic asthma. So the starting point for identifying these phenotypes and endotypes, as often is the case, actually starts in the clinical assessment of patients. And certainly there have been concepts in the asthma world regarding intrinsic and extrinsic asthma for many years. And those were sort of discarded in the late 90s. And intrinsic and extrinsic asthma wasn't felt to be helpful anymore because, everyone had a Th2 inflammatory process. Well, I think that was a little bit premature, and I think there's a lot of evidence to support that it was a little bit premature. But going back, after the intrinsic-extrinsic asthma had been sort of discarded, in 2004, in my cohort of severe asthmatics at National Jewish, which was about 100 patients, I kept seeing these patients and saying, there's a huge difference on when you got your disease. If you got your disease before the age of 12 or you got your disease after the age of 12, your clinical presentation is going to be very different. So I decided, okay, let's just divide my 100 patients into those who got their disease before the age of 12 and after the age of 12, early and late. And when we looked at atrophy, it was very significantly different in the early onset versus the late onset, but there's still 75% of late onset individuals that are atopic by skin testing, although 100% are of the early onset. But then if you looked at allergic asthmatic reactions to various allergens, house dust, bird animal seasonal pollen, about twice as many of the early onset individuals said, in fact, that they recognize those symptoms most or all of the time compared to the later onset individuals. So a much stronger relationship with allergy. The history of eczema, which is much greater in early onset compared to late onset, 40% versus 4%. Interestingly, that statistic is exactly the same as Rakeman or however you say his name, that was the father of intrinsic and extrinsic asthma. 40% versus 4% is the difference in intrinsic and extrinsic asthma. Serum IgEs tended to be higher in early onset. And then I think very importantly from the standpoint of genetics, early onset asthma has a much stronger family history of asthma than later onset disease does. And that, I think, has been validated now by several of the GWAS studies, which have found much stronger associations of genetic polymorphisms with early onset asthma as compared to later onset asthma. So I think all of this suggesting that age at onset is, in fact, a relevant item. Now,
Question. The IgE data, you sort of categorized it into 2 groups. How does that match with the classic Burroughs sort of straight line data that the higher your IgE, the greater your risk of having asthma, like there's just a linear straight line?
Well, and I don't, again, I agree that there is a relationship. I think all of the human data is not a perfect line. Late onset disease is probably still the smaller percentage of asthma. I think most people still get their asthma in childhood, and so this may very well get lost. Now, I have to say that there's people with late onset disease that have high IgEs too.
And they may also be non-atopic, right? They don't have to.
Absolutely,
Yeah.
absolutely. So it's a
Right.
yeah, it's a funny relationship, and I will see people to Steve's point that are completely non-atopic and have IgEs in the 500 range, and they don't have ABPA, they don't have bronchiectasis, etc. They have non-specific IgEs, or IgEs that we can't figure out what they are, and we call them non-atopic, but they've got IgEs of 500. What is that? Anyway, so I've been fortunate enough to be part of the Severe Asthma Research Program, the SARP. And of course, we started out with this clinical concept of phenotyping, but I think there's been a big move to say, well, that clinical stuff, that doesn't really mean that much. That's your observations. What about if we just take all the data and do some statistical, unbiased analysis? So this was done as part of the SARP network, and it was about 750 patients that were clustered using about 35 variables that had been ranked in a hierarchical fashion. And using those data, they were able to actually identify 5 different clusters. Now, interestingly, in this analysis, the most important discriminators were lung function testing and age at onset. So I was quite happy to be validated that even using statistical approaches, there was still evidence that when you got your disease was really a critical factor. And this is the way the 5 clusters broke down. 3 of them, majority, 75%, fell into this early onset group of individuals with mild to mild, moderate to severe atopic early onset asthma. And then 2 distinct clusters that were later onset asthmatics who were less atopic, one of whom was primarily female, very late onset, sort of mid-40s, and then this group was more mid-20s, but the worst quality of life, the worst airflow limitations, etc. But again, defining it primarily by age at onset. Well, that's all nice, but that's still clinical. Then are we going to get to the biology of the disease? And I think a big step was taken by our colleagues at UCSF a few years ago when they looked at some microarray data from epithelial brushings of asthmatics. Now, they had interestingly published microarray data in the PNAS the year or 2 before this, where they just took asthmatics and they compared them to healthy controls, and they found 7 genes that differentiated the asthmatics from the normal controls. Not very remarkable at all. And in fact, half of those were mast cell genes, which was kind of interesting. But they then went back and said, well, we're missing something. So they went and they took epithelial cells, they put them into culture, and they stimulated them with IL-13. And then they looked to see what these cells made. And they made many things, but 3 of the things that they made were periostin, ClipKA1, and serpin B2. So they went back to their epithelial brushing samples that they had gotten from these very mild asthmatics, and they looked for the expression of these 3 genes. And I think what they found was striking, and I think is going to set our course for describing asthma phenotypes and endotypes for the next many years, is that about half of these individuals had very high expression of these IL-13 related genes. The other half were indistinguishable from the healthy controls. There was absolutely no evidence that they had IL-13 expressed genes. And then they went and they looked at those patients that had the higher expression of the IL-13 related genes, and they were more likely to be atopic, had greater number of eosinophils in their tissue, had more bronchial hyperresponsiveness, and they were really identified by this increase in epithelial periostin. Now, I think the more important aspects of this study, however, were really related to some of the structural changes that one saw in the airways, that in fact, if you had a Th2 high type of asthma, you actually had a much thicker subepithelial basement membrane. This was very similar to data that we had published 10 years earlier, in that if you had eosinophils in your airways, you were very likely to have a thickened subepithelial basement membrane. So again, it was nice that this was confirming that sort of relationship. But the most important element was the follow-up inhaled corticosteroid study. So again, these were all mild asthmatics, no inhaled corticosteroids. They treated them for 8 weeks with inhaled corticosteroids, low-dose inhaled corticosteroids, and they looked at the response in FEV1. And here's the Th2 high group. You can see very nice, robust improvement in FEV1 over the course of treatment. If you were in the Th2 low group, you had 0 response to inhaled corticosteroids. And remember, this is half of the population here is in this low Th2 low group. This has enormous implications for the way we treat our patients. Now, obviously, this has to be replicated in a large-scale clinical trial, but I think it's very conceivable that there's a good percentage of the asthmatics out there that we actually don't need to treat with inhaled corticosteroids, that will do just fine without treatment with inhaled corticosteroids, or may need some other treatment, but inhaled corticosteroids are not going to be their drug of choice. So this, I think, leads us to the direction of endotyping. Like I said, we're really not there, but I think this initial phase is the endotypes of Th2 light high and Th2 low types of asthma. Now, if you say that, well, how are you going to define Th2 high? Atypy and IgE, I think most people sort of make a connection between Th2 high and atypy and IgE. I think they're actually probably the worst indicator. That there's a whole host of mild asthmatics that have atypy by skin testing who do not have any evidence of a Th2 immune process. So that's probably the worst indicator. Early age at onset, yeah, the earlier the age at onset, the better. So if you're before the age of 2, I think that's a pretty good indication that you're going to have a Th2 high asthma, but probably still not great. I think there's a lot of data now to support blood and lung eosinophils is related to Th2 high. If you never see an eosinophil in somebody either in their blood or lungs, it's very unlikely they're going to have Th2 high asthma. Exhaled nitric oxide, we talked about that last night. I think exhaled nitric oxide can in fact be a marker for Th2 high asthma. Presence of mast cells, hard to measure, but yeah, that's probably an indicator of Th2 high. And then finally, this gene profiles and biomarkers, which a lot of interest has been placed into periostin, and I'll talk about that a little bit further.
Question, Sally, on the mast cells. How good a marker is the carboxypeptidase A3 positive mast cell, kinase negative and tryptase positive? Is that a marker?
I think that's a very nebulous area at this point. You know, I know the UCSF group has felt that there's this distinct phenotype that is CPA3 positive kinase low. We don't think that it's always that way. It probably can be that way, but our data from the Blue Journal a couple of years ago really suggested a pretty strong relationship between the kinase positive mast cells and the CPA3 positive mast cells in severe asthmatics. So it may depend upon where you are in the spectrum of disease too. You know, how plastic these cells are. I don't think anybody knows really how plastic these cells are. Steve?
I was just a little confused by the atypy IgE as a bad indicator. I mean, so if they have moderate asthma by symptoms and spirometry and a history of immediate rhinitis symptoms after, or wheezing after exposure to cat or whatever.
Well, I think
that's
yes, that's the caveat.
Okay.
Many people will just look at, some people will just look at the skin test and say, oh, you know, you've got a bunch of positive skin tests, you must be a Th2 high asthma. No, there has to be.
So it's like food allergy. It's all in context with.
Yes, it's all in context with that. Absolutely. Okay, I'm just going to make my point about Th2 low. How do we define Th low? Lack of any of those markers. So really pretty poor definition of Th2 low. But I like to, again, point out that I think this Th2 high asthma is more than allergy, and not all allergic, quote, allergic asthma may be Th2 high. So I think this is an important thing to remember. Exercise-induced, I think Teal Halstrand here at the University of Washington has a pretty good track record for showing the high degree of mast cell activation in exercise-induced asthma. Mast cells, I think, track pretty nicely with the Th2 profile. And there is a very interesting, very small study that showed that anti-IL-9, which is a mast cell chemoattractant, actually improves exercise-induced asthma. So again, supporting the concept that the mast cell is involved, that IL-9, which has been in the spectrum of Th2 cytokines, is also involved in exercise-induced asthma, at least in some exercise-induced asthma. And then one that I think is not discussed very often is this adult onset persistent eosinophilic asthma with a subtype of aspirin-exacerbated respiratory disease. But trust me, there's an awful lot of people with adult onset eosinophilic asthma that don't have any evidence of aspirin-exacerbated respiratory disease and still have this Th2 type of phenotype.
Oh, yeah, I'm surprised that have exercise there, because it's usually a relatively benign thing that people grow out of, and you would think if it's driven by Th2 cells, it'd be a much more persistent and perhaps severe condition.
But I think, again, that's a good point. I think we don't understand the spectrum of Th2 disease yet. And I think there are exercise-induced asthmatics that don't have a Th2 type of process for sure. But I think Thiel's data on mast cells is really pretty good. And I think the anti-IL-9 data, no one's going to use a biologic, no one's going to use anti-IL-13 to treat exercise-induced asthma. So we'll probably never know for sure what that Th2 link is. But I think if you can confirm that link between mast cells and exercise-induced asthma, there's a pretty good suggestion that it's a Th2
And
process.
there's treatment data with inhaled steroids as like monotherapy for exercise-induced asthma.
Right,
It works pretty well.
Right, and obviously treating for a month or something beforehand, so that you lower your epithelial mast cells, so that you can improve the response. So those, I think, are the three broad categories of Th2 high, the Th2 high endotype of asthma. I think we have to ask the question, can you identify Th2 asthma in more severe asthma? And again, this is another very important study that was published last year in the New England Journal of Medicine. 200 patients with moderate to severe asthma on mid to high dose inhaled corticosteroids, most on a long-acting beta agonist, randomized to treatment with anti-IL-13, the Th2 cytokine, versus placebo. Anti-IL-13 was modestly effective in improving FEV1 in all comers. You can see no one would get too excited by this difference from placebo. However, they had a secondary analysis designed, which was to target Th2 high versus low. And initially they had sort of done it with blood eosinophils and IgE levels, and that didn't turn out to be really very helpful in discriminating responses. But they'd also, living in San Francisco like Genentech does, had this collaboration with the UCSF group, and they thought, well, let's measure periostin. Let's measure that periostin that we found in the epithelial cells in the airway. We know it's secreted basally into the blood, so we ought to be able to pick it up in the blood. So they developed an assay for periostin and divided the patients very simply by a median split, so just high versus low periostin. And what they found was those individuals in the high periostin group had a much more robust improvement in FEV1 through the course of the study as compared to those who were periostin low. So I think reasonably good phenotypic, endotypic data to support the role of IL-13 in some of these patients, but really not in others. Now, they also did this split with exhaled nitric oxide, and lo and behold, if you did a median split with exhaled nitric oxide, you got very similar data, in fact, maybe a little bit better with exhaled nitric oxide. Now, most of us don't have anti-IL-13 to throw at our patients yet, but I think this is probably an indicator of corticosteroid response too. And so I think if you can measure exhaled nitric oxide, measure periostin, it might give us a little bit of an indication of who's going to respond to steroids or not. Now, in addition to exhaled nitric oxide being a biomarker, there's also data that would suggest that you can follow exhaled nitric oxide to see if there is a biologic response. Now, exhaled nitric oxide is believed to be produced by the enzyme inducible nitric oxide synthase. Now, there's always been a lot of controversy with inducible nitric oxide synthase. It's present in macrophages, it's present in the epithelium, but studies for many years did not show any relationship with Th2 cytokines. In fact, the only way you could get an increase in the enzyme was actually combining a Th1 and a Th2 cytokine to induce inducible nitric oxide synthase. That was in animal models, that was in cell lines, etc. Well, interestingly, if you do an air-liquid interface cell culture system, and then stimulate with interleukin-13 and a more differentiated cell type, in fact, you see a very nice increase in inducible nitric oxide synthase, both at the RNA level and at the protein level. And this is data that we published back in 2008. And it's, again, very nice to be validated that when you treat someone with an anti-IL-13, in this high exhaled nitric oxide group, you get about a halving of the exhaled nitric oxide levels in the presence of an anti-IL-13. And granted, maybe that's not a knockout mouse, but that's actually relatively close to be able to confirming in a human being that IL-13 is in fact a very important driver of the exhaled nitric oxide levels that we're measuring in the clinic. If you look at the exhaled nitric oxide low group, there's still a little bit of a decrease. So even in the exhaled nitric oxide low group, there may be a little bit of IL-13 left to actually decrease the exhaled nitric oxide further. Now, I'm sure many of you all have exhaled nitric oxide in your offices. You've played with it a little bit. If you don't, I'm sure many of you will agree that exhaled nitric oxide, for all that lovely data there, is a very confusing molecule. That sometimes it's high, sometimes it's low, sometimes it responds to steroids, sometimes it doesn't respond to steroids, sometimes it's an indicator of noncompliance, sometimes it's not. As part of my involvement with the Severe Asthma Research Program, we were fortunate enough to get a recovery era grant to look at microarrays from epithelial cell brushings of our severe asthmatics and our controls in our population. And we're not finished with it yet. We're analyzing the last 50 of these. But this is the first 100, basically, of the epithelial microarrays that we did, which is the largest bank of microarrays of any group that I'm aware of. Anyway, we had 96 subjects that had matching exhaled nitric oxide data. And so we did a very simple k-means clustering approach to analyzing the gene expression data in relationship to exhaled nitric oxide. Now, the exhaled nitric oxide data was obtained the same day as the brushing, so we're pretty confident that this is a strong biological relationship. We picked the top 500 or so genes that correlated at an R value of 0.5 or greater, p-value of less than 0.05 by a false discovery rate correction. And doing that, we were able to identify 5 major subject clusters. 3 with high exhaled nitric oxide, clusters 1 to 3, and 2 with low exhaled nitric oxide clusters values. And I think you can see here are the exhaled nitric oxide levels, 44, 48, 42, indistinguishable. We saw that somebody in our office who had an exhaled nitric oxide of 44 versus 48, we would say it's the same thing, basically. And then 2, 18 and 20, again, indistinguishable clinically. These were associated with differences in 5 to 6 major gene clusters. The first batch up here are what I call Th2-related genes. These are mucus-related genes, mast cell-related genes, epithelial repair-related genes, and sort of a catch-all metabolic genes. But I think you could see that the gene expression patterns across these 5 clusters are actually relatively distinct. Now, that's nice, but what does it mean clinically? How can you have 3 groups of people with the same exhaled nitric oxide, but all this different gene expression that's occurring? So we actually went and looked at relationship to FEV1, bronchodilator response, etc. High exhaled nitric oxide, very clear. If you're in cluster 1, you have an FEV1 of 98% predicted. If you're in cluster 3, you have an FEV1 of 56% predicted. Dramatically different. If you have, in cluster 3, you have a very profound bronchodilator response, very bad quality of life, but really no different from the quality of life in cluster 2. So both of these 2 are enhanced for the more severe asthmatics. Again, no difference in age, and no difference in BMI, interestingly. If we look at the low exhaled nitric oxide groups, again, one of those stands out as the more severe of the 2, 80% versus 88%, stronger bronchodilator response, worse quality of life, higher age, and in this case, a higher BMI. So I think using this gene expression profiling, there's an indication that maybe we can start to define endotypes. And if we go a little bit further and look at things like percentage of eosinophils in the BAL, here's cluster 1, 2, and 3 of the high exhaled nitric oxide group. Very nice distinguishing increase in eosinophils. Low exhaled nitric oxide, very little in the way of eosinophilic inflammation. Oral steroid use in the past 3 months, none in cluster 1, 20% in cluster 2, 70% in cluster 3, and then modest in the low exhaled nitric oxide groups. ER visits, urgent care visits in the last year, very minimal in cluster 1, 75% in cluster 3, and sort of intermediary in the low exhaled nitric oxide clusters. But this was rather intriguing, I thought, in that we looked at the percentage who had nasal polyps. The percent with nasal polyps in cluster 3 is 35%, dramatically higher than any of the other clusters, and really suggesting again that this gene expression profile in relationship to exhaled nitric oxide is very distinct in this cluster as compared to 1 and 2. If you looked at sinus surgery, this is a history of sinus surgery. This is not I complain of a stuffy nose. This is I had sinus surgery. 40+% of cluster 4 have a history of sinus surgery compared to 10% in cluster 5. So even though we may not be able to define that group quite as well biologically, there is still something quite incredibly different between the two groups based on this very distinct pattern in relationship to sinus surgery.
I'm just curious, if you went back to old, I hate to say this, old terminology and said, well, those are intrinsic asthmatics and those are extrinsic, I'm tempted to wonder if the people who've had sinus surgery and chronic rhinosinusitis are what we would have called adult onset intrinsic asthmatics, and now we just know more about their biology.
Maybe, but I actually went back and did look at age and onset in relationship to these 5 clusters. Doesn't mean anything in relation to these 5 clusters.
So do you think there's potential for using the cluster as a stamp on their forehead and say, okay, you should be able to follow ENO as a major marker that's easy versus somebody else who you have to follow?
Well, I think that's the idea. And one of the things that we're going to do as part of SART-3 is there actually will be a longitudinal component to SART-3, which is going to be very nice. And we actually have a steroid intervention. So everyone gets a triamcinolone shot, a lowish dose, 40 milligrams of triamcinolone. And then we'll bring people back and measure the exhaled nitric oxide again. And my guess is that if you're in cluster 1, your exhaled nitric oxide will go down to zip. If you're in clusters 2 and 3, it might go down a little, but it's not going to take the major hit that cluster 1 will. Yes, sir.
Some asthmatics will respond to leukotriene antagonists, about half of them. Mm-hmm. Half of them will respond to anticholinergics. The response to various different medications, response to beta agonists with their beta cluster. Are you looking at any of those markers?
We don't, because of SART being a cross-sectional database, we don't really have response to medications. We can have whether you're on medications or not, but really not response to them.
So it would be very practical.
Yes, and I think, again, moving forward into SART-3, when we have this longitudinal component, you'll be able to look at it, to evaluate those sorts of things. But right now, I don't have any information on it, unfortunately. Well, I already talked about mast cells and the relationship of mast cells to Th2 types of asthma. This is based on this study by the UCSF group again, where they took their Th2 high and their Th2 low groups, and they found that in the genes that were differentiating, they were enhanced for all these red genes, which you can't read, but are mast cell-related genes. And so this actually stimulated us to look in our severe asthmatic population, and really for the first time looking in formal and fixed tissue, which is embedded in paraffin and allows you to have thicker sections. And lo and behold, when you look in a thick section biopsy, there's lots of mast cells in the epithelium. In a thin section biopsy, because probably the section is too thin, you can't pick up the mast cells. But there's a lot of mast cells in the epithelium. And in fact, we published a paper in 2010 that literally said that the severe asthmatics had the highest percentage of kinase-positive mast cells in the epithelium, that it specifically differentiated severe asthma from milder forms of asthma, and identified a very poorly controlled group of asthmatic patients, much better than the submucosal mast cells did. So we obviously already have a mast cell-directed therapy. We have anti-IgE that has been around for a while. And I think one of the conundrums for most of us, kind of like exhaled nitric oxide, is, well, who really gets better with omalizumab? And there's never really been a good way to predict. Even when somebody's got a lot of positive skin tests and something that sounds like an allergic disease, they still don't always respond to omalizumab in the way we'd like them to. And so the extra study that was published last year was done on a pretty severe group of patients who mostly met the ATS criteria for severe asthma and had a reasonable response, probably similar to what they've reported previously in reducing exacerbations. But because of their interest, Genentech's interest now in periostin, of course, they went back and said, in a retrospective manner, looked at that study and divided their patients into two categories on the basis of exhaled nitric oxide, blood eosinophils, or periostin, using pretty much the same values that they had used in the lebrikizumab paper. And you can see that these exhaled nitric oxide levels are really pretty modest. I mean, I would never consider 20 to be a high exhaled nitric oxide level, but falls into the high exhaled nitric oxide level in this study. Anyway, very similar to what you see with the lebrikizumab. If you're in the high exhaled nitric oxide, the high eosinophil group, or the high periostin group, it predicts a much better reduction in exacerbations as compared to being in this low Th2 group. This is with a medication that we already have, that I think we can potentially now start utilizing to predict who's going to respond to an expensive biologic medication. So I think this is really exciting. This is retrospective, probably still needs to be done in a prospective manner, etc., but I think very suggestive that a Th2 high group of patients is going to respond to a Xolair. So I also mentioned this atypical Th2 disease, eosinophilic adult onset asthma. This is from one of my adult onset asthmatics that actually died of an asthma exacerbation, and she had struggled for a long time getting IV Solu-Medrol literally every day for weeks at a time. Despite that, when she died, this is what her pathology looked like. You've got an epithelium that is grossly abnormal, lots of goblet cells in this epithelium, hyperplastic, thickened subepithelial basement membrane, and then eosinophils just packed in here in the submucosa, migrating through the epithelium into the epithelium and on into the lumen, which is just occluded with a mass of mucus. And in fact, she died of hypoxia from the standpoint that her airways were so obstructed with mucus. So this hypereosinophilic adult onset asthma, adult onset, severe, persistent eosinophilic asthma, despite high doses of inhaled corticosteroids and often requiring systemic corticosteroids, usually associated with sinus disease, not always with polyps, but certainly commonly associated, and sometimes aspirin sensitivity, probably is enhanced in that cluster 3 of the exhaled nitric oxide data that I showed you, can respond well to 5-lipoxygenase inhibitors as opposed to leukotriene receptor antagonists, but it's probably 30 to 50% that will respond some to a 5-lipoxygenase inhibitor. The relationship of this group to Th2 immunity has been less clear. They're less often to be allergic. The IgEs, as I already kind of mentioned, are variable. There are some data in the ENT literature to suggest that periostin is upregulated in nasal polyp gene expression arrays, and they have very high exhaled nitric oxide levels. So I think there's been both biased and unbiased approaches that have identified eosinophilia with late onset disease, and for some reason or other I think the common wisdom has been, well, eosinophilia goes along with allergic asthma, but that's not really the case, I think, especially once you've started therapy. These are data that we published again in 2004, where we looked at our patients with early and late onset asthma, looked at endobronchial biopsies, saw that in early onset asthma, there were actually lower levels of eosinophils in the tissue as compared to late onset asthma, kind of the opposite with lymphocytes, interestingly, but a prominent eosinophilic inflammation in late onset disease. This was confirmed by the cluster analysis that was performed in the UK, using sputum as one of the variables they identified in an inflammation-predominant late-onset group of patients with severe disease that, again, were hallmarked by high levels of eosinophilia. In our study, this increase in eosinophils in late-onset disease was associated with high urinary leukotrienes, less ATP, more aspirin-sensitive-like disease. And we published a paper just in the last couple of months which suggested that this late onset eosinophilia is actually associated with high levels of epithelial eotaxins. So again, a chemoattractant for eosinophils that might be driving the sputum eosinophils. Now, I think the biggest thing that confirms this relationship to Th2, however, is the use of the biologics once again. The first study, of course, with anti-IL-5 that really showed fairly substantial efficacy was published back in 2009, and this was in marked contrast to what had been published earlier in milder, more generalized asthma, where anti-IL-5 really didn't do anything to treat more generalized types of asthma. But in the paper by Ian Pavord's group, they did a targeted approach to eosinophilic asthma. If you had a history of 3% eosinophils in your sputum at some point in time, there was about a 40% reduction in asthma exacerbations. Interestingly, no effect on FEV1, no effect on symptoms, but a pretty profound effect on exacerbations. If you look at the demographics of these patients, the majority of these patients in the study were actually late onset eosinophilic asthma. So again, sort of I think confirming that IL-5, a Th2 cytokine, is related to this eosinophilic type of asthma. Now the more recent data are actually suggesting that in fact blood eosinophils may give you the same sorts of response. This was from Ian's follow-up paper that was published in The Lancet earlier this year, basically where instead of using sputum eosinophils to predict response to therapy, they actually use blood eosinophils. And I think you can see that even using blood eosinophils as your marker, that all of the groups that were treated with mepolizumab had a decrease in exacerbations as compared to the group that was on placebo. And basically what they did, which was kind of an interesting analysis, was that they took the curves for the baseline eosinophils and the probability of having an exacerbation in the previous year, and basically divided into those who had a history of greater than 4, 3, or 2 exacerbations. And if you're on placebo, this was your relationship of blood eosinophils to numbers of exacerbations. So the more blood eosinophils you had, the more likely you were to exacerbate. But in the patients that were put on mepolizumab, again with blood eosinophils, there was a very profound reduction in all of the dose groups in relationship to the placebo arm's predicted exacerbations over the course of the study. And what they were able to show is that somewhere around 200 here, 200 blood eosinophils, not really high blood eosinophils, you were actually able to start seeing this effect of improvement with the drug as compared to the placebo. Well, I think because anti-IL-5 doesn't have an effect on FEV1, doesn't have an effect on symptoms, the lebrikizumab data with IL-13 shows a nice effect on FEV1, maybe an effect on exacerbations, but no effect on symptoms, no effect on quality of life. You have to ask the question, even in this, quote, Th2 high type of asthma, is it more than a Th2 inflammation? And so we published a paper back in August in the Blue Journal, which was kind of a case series, actually, of 10 severe patients that were referred to me at the University of Pittsburgh, all of whom were corticosteroid-dependent asthmatics, mean age of 52, generally late onset, but not always, who had a lower than expected diffusing capacity, about 76% are predicted, with very little evidence for air trapping. So really more of a mixed obstructive restrictive sort of disease, but met the criteria for asthma, had a reduced FEV1, reduced FEV1 FVC ratio, and a response to bronchodilators. They all had prominent sinusitis, this was clear. And if you looked at their blood eosinophils, despite being on systemic corticosteroids, still high. IgEs kind of varied all over the map, but exhaled nitric oxide, again, still generally high in this population. Now, me being somebody who's literally asked this question for as long as I've been interested in severe asthma, I really want to know what's going on pathologically in these patients who are corticosteroid-dependent severe patients. And unlike interstitial lung disease, we never, as pulmonologists, get tissue on these people. Maybe we'll get endobronchial biopsies, but endobronchial biopsies are teensy-tiny little pieces of tissue that show you very little. And I think one can ask the question, well, you know, your blood eosinophils are a little high. Do you really have a Scherk-Strauss? Is this something that I'd see a vasculitis in? Is it possible this could be a variant of hypersensitivity pneumonitis? So I rationalized that and said, I want to get thoracoscopic biopsies on these patients. So we got thoracoscopic biopsies, and we've gotten now thoracoscopic biopsies on probably about 25, but these are the purest cases. And what we found was actually incredibly surprising. So we found small airways that looked exactly what you'd probably expect to see in a severe asthmatic. A very dense mononuclear and eosinophilic infiltrate around this airway, extending out into the interstitium to some degree. Lots of goblet cell hyperplasia, thickened subepithelial basement membrane, big old mucus plug here in this airway. Then what we found over here was very surprising. There are little granulomas over here. Now, as far as I know, other than maybe an occasional case of Scherk-Strauss, which is associated with granulomas, there's no association of a granulomatous airway or interstitium in a patient with asthma. And yet, they were there. Now, given that, and the potential overlap with a hypersensitivity pneumonitis or an autoimmune disease, although these patients gave no history of any exposures to typical hypersensitivity sort of antigens, I decided to try treating these patients with alternative immunosuppressives. So we actually used azathioprine and mycophenolate as our two most commonly used drugs. And the response isn't perfect, but it's probably 70% or so of the patients that we've treated have had a robust response to an alternative immunosuppressive agent. Now, obviously, we need to better understand what this is, what the meaning of this is. What is that underlying pathobiology that's driving that? But I think it has to make us start to think outside the box that even in Th2 high asthma, it's more complex than just a Th2 cytokines. Interestingly, if you actually do the family history, and really good family history on these patients, there's very little history of asthma, although there's some. But it's a very strong history of autoimmune disease in these folks, so they have a mother with rheumatoid arthritis or something. So I think there's going to be an overlap. And even to the gentleman's question on the clotting disorders in relationship to asthma and severe asthma, I don't particularly know of a relationship other than an acute pulmonary emboli can cause you bronchospastic reactions. But one of the things we've seen in a few of these biopsies is actually some microemboli or microthrombotic disease in the patients. And I'm now checking antiphospholipid anticardiolipin antibodies on these patients. And we've had about 50% of the patients come back with positive anticardiolipin antibodies or a poorly defined lupus anticoagulant. So I think, again, there may be even a vascular component to this that we don't fully understand. Okay, the last part of the talk is going to be a little bit on Th2 low asthma, defined as an apparent absence of Th2. I think you have to be really careful because sometimes corticosteroids could profoundly suppress Th2 inflammation, and so you may be a little bit misdirected in thinking it's a Th2 low type of asthma, much less well defined, generally adult onset, includes obesity-related, post-infectious neutrophilic, smoking-related, etc., and really all are associated with a poor corticosteroid response. This is more data from the UCSF group. This was a paper published earlier this year where they took the patients that had been in the Asthma Clinical Research Network trials that had been treated with inhaled corticosteroids, and they divided them on the basis of whether they were persistently eosinophilic, intermittently eosinophilic, or never eosinophilic on the basis of their sputum. And I think you can see that the eosinophilia, again, was the lack of eosinophilia was related to things that we kind of associate with a non-Th2 type of process. So the less eosinophils you had, the more likely you were to be overweight or obese, and the lower your IgE. So again, this less atopic sort of patient. And then again, if you start looking at inhaled corticosteroid response, here are the patients that are persistently eosinophilic, and you can see they get a very nice response to inhaled corticosteroids. Here's the group that's intermittent, a little bit of a response, but boy, if you're non-eosinophilic, there's flat, no response to inhaled corticosteroids once again. Now, I think it is important to look at the starting FEV1s. If you're persistently eosinophilic, your FEV1 is 75% predicted. If you're intermittently eosinophilic, you're 85 to 90% FEV1. And my personal bias is this association with the Th2 type of inflammation is really associated with a more severe disease, that the non-Th2 or Th2 low asthma is not quite as severe a disease, even though there's been a lot of interest in, defining what this Th2 low type of asthma is. I think another study to really support this complexity of this low Th2 asthma was done by my friend Ann Dixon at the University of Vermont, and probably the best study in obese asthma to date, where she took 23 obese asthmatics and evaluated them 4 and 12 months after bariatric surgery. Interestingly, there were 41 asthmatics initially entered into the study, but they lost 9 of them because they either didn't have bronchial hyperresponsiveness or bronchodilator responsiveness. Again, obesity is commonly mistaken as asthma because they complain of shortness of breath, and it's really their obesity that's driving the shortness of breath, not the asthma per se. But in those that qualified, the BMI decreased profoundly from 51 to 38, and there were significant improvements in symptoms, in FEV1 and FEC, as well as PC20, but the greatest improvements were in forced vital capacity, probably just because of the mechanical effects of having less thoracic weight. But then she did something I think that, again, is in helping us to understand endotypes. She roughly phenotyped the patients by the median IgE. And in this study, there were really distinct differences in IgE levels. So the median split gave you a low group with a median of 25, a high group with a median of 305. So really distinctly different. And what she found was the later onset, low IgE, obese asthmatics had a very nice improvement in their PC20 in response to bariatric surgery, in response to weight loss. If you were in this early onset, high IgE group, you had no improvement in PC20. And I think this strongly suggests that the obese adult onset asthmatic is in fact a distinct phenotype, perhaps driven by metabolic pathways related to obesity, etc., that responds to weight loss. But if you got that allergic early onset asthmatic, they might feel a little bit better because obviously they're not carrying as much weight around, but their asthma in itself is probably not going to improve. And I think to sort of build on this is my colleague Fernanda Holguin, who works with me at the University of Pittsburgh. We've actually looked back at the SARP database, looked at late onset obese asthma and early onset obese asthma, or late and early onset asthma. And this has been reported before, of course, that exhaled nitric oxide levels tend to be lower in obese patients. Well, if you actually divide them out into early onset versus late onset patients, the relationship only holds true in late onset disease. So the heavier you are with the late onset disease, the lower your exhaled nitric oxide. On the other hand, if you're early onset, again, there's no effect on exhaled nitric oxide. And he's been very interested in the involvement of other metabolic factors that have been associated with metabolic syndrome, one of which is asymmetric dimethylarginase, or ADMA, which is a naturally produced inhibitor of inducible nitric oxide synthase. And basically looking at the levels of this in relationship to arginine in the blood, actually in late onset compared to early onset disease, and I think showing a very nice relationship to increasing levels of this ADMA in late onset disease, which doesn't seem to exist in early onset disease. So again, at least a start to suggesting there may be some metabolic pathways that are really distinctly different from what one would evaluate in an early onset patients. So I'm just going to conclude by sort of my latest concept of Venn diagrams, which of course is continuously changing and evolving, and 2 years from now it won't look anything like this, I'm sure. But I think we can begin to divide patients into this Th2-like and non-Th2 types of disease, that you can divide the Th2 into childhood onset and adult onset. Most of this non-Th2 is going to be adult onset. These are all the cases that I've talked about in relationship to Th2 disease, with increasing involvement of Th2 related to increasing severity, but also an emergence of a non-Th2 sort of process as you get into more severe disease, and then the array of non-Th2 diseases here. So I think I will stop there. I thank you very much for your attention, and I'm happy to take any additional questions.
You talked about sinus disease-associated asthma, and then at the end you had your categories. You didn't mention that again in your final slide. Do you think that's a separate phenotype again, or is that?
No, I don't think it's a separate phenotype. No, I think the sinus disease is associated with adult onset disease. I think that's pretty clear. I think and I think there may be a couple different types of sinus-related asthma, one of which is the adult onset eosinophilic, very profoundly sinus-related sort of process. But then I think there is probably another group of late onset, less Th2-like disease that has a profound sinus connection too. And I think exploring those avenues, and the nose and the sinuses are more accessible than the lungs. If we figured out what was going on in the nose and the sinuses, I think it would have a lot of, give us a lot of help in understanding what was going on in the lower airways.
Okay, one more question. If we don't have exhaled nitric oxide, do you think periostin can separate these two groups?
Well, I think periostin might be able to. The relationship between periostin and exhaled nitric oxide is reasonably good. But as far as I know, there's still not a commercially available periostin assay. I think Roche is trying to develop this as a diagnostic to go along with their anti-IL-13 program. Now, you could argue that based on their Xolair data, they'd be able to use it for Xolair. But as far as I know, there's not one available yet. But bloody eosinophils are not bad. So everybody can order a CBC.
Nitrous oxide's not hard to do.
No, it's not. You have to invest in the equipment.
20 seconds.
Do you think we know enough yet with available tests, at least to a specialist, to make therapeutic decisions and say, well, obviously, this patient's got a better likelihood of responding to drug X or Y?
I think because we don't have very many specific choices yet, other than perhaps omalizumab and rheumatoid modifiers. I think going down specific targeted pathways, we're a little premature just because we don't have that many to go down. I think we're going to start making decisions on inhaled corticosteroids and systemic corticosteroids, though, based on the phenotype, the endotype of the patient. The AsthmaNet, the child of ACRN and Care, is actually doing a 600-patient trial, dividing patients into those that have eosinophils and those that don't, treating them with inhaled corticosteroids for a longer period of time, and determining whether there's a difference in response, a difference in outcomes in the group that's non-eosinophilic compared to those that are eosinophilic. And I think all of us, if we're betting people, would bet on the group that's eosinophilic being the responders, and the non-eosinophilic group of mild patients really not needing the inhaled corticosteroids and maybe doing just as well on placebo with the PRN albuterol for that matter. So I think from the standpoint of mild patients, we may be getting there. From the standpoint of more severe patients, I actually tend to use blood eosinophils, sputum eosinophils, and exhaled nitric oxide to determine whether I'm going to bump up somebody's oral corticosteroids, or am I looking for other comorbidities that might be playing into their worsened symptoms. But if I've got somebody whose exhaled nitric oxide or blood eosinophils have gone from 200 to 300 or 30 to 60, it's like, I'm going to increase their systemic corticosteroids or find an alternative to them. So I think we're starting to get there, Lou, but once we get the targeted biologics, the IL-13s, the IL-5s, et cetera, then I think we'll have a much better sort of menu to choose from.
How long a steroid trial will you use before you switch off to mycophenolate or Imuran?
Well, all of these patients are patients that I've seen for at least a year. So I don't, just indiscriminately start doing biopsies and treating with these alternative immunosuppressives. But after a year, I'm doing the biopsies, and I think at this stage, people say, well, can't you just try to treat me with this? And I feel a little bit uncomfortable with that because this is not a standard medication for asthma in any way, shape, or form. If somebody gets into trouble, I'd like to at least have some proof that there was something other than asthma there that I was treating. Plus, I think we're learning in the process by collecting these samples, and all of these are going into a tissue bank, and we're going to be able to go back and do gene expression profiling on the granulomatous areas, et cetera. So I think we'll get better. But I have to see the patient for at least a year. Yes, sir.
Hi. I've got to remember not to sit behind Paul because he always answers my questions when I have a question. I was intrigued by that paper of the granulomatous disease you had.
Mm-hmm.
I can't remember anything about it except for reading it.
Glad you had that profound
like a lot of what I'm reading, I can't remember what it almost seemed like a whole separate syndrome that's never been defined before.
Yes, that's what we.
So half of them have lupus anticoagulation, surprising amount of corticosteroid resistance. What are some other characteristics of this group of patients?
Well, as I kind of suggested, these are patients traditionally late onset, or if they're early onset, they tell you that, yeah, my asthma was always okay, and then I had some event, exacerbation, and ever since I had that exacerbation, it's been really hard to control.
Do they have arthritis? Any other
No.
characteristics?
Well, sometimes they'll have some arthritis, but it's not a deforming arthritis. I mean, it's not like you can say, oh, there's a rheumatoid component here. But they will complain of joint aches and pains. But, they're on steroids. Everybody complains of joint aches and pains. So it's a little hard to hang your hat definitively on that. SED rates are pretty normal. CRPs can be a little high. I think the thing that always triggers me is, again, late onset disease, no evidence of air trapping on full lung volumes. So you'll have a decreased FEV1 to FEC ratio, but no air trapping. And then this lowish diffusing capacity. So traditionally, asthma is supposed to have a normal to high diffusing capacity. So anything that's on the low side is a little suspect.
For vitamin D levels, just a quick question. Any differences in any of your groups?
No. And by the time most people come to me, they're already on vitamin D, and so their vitamin D levels are fine.
Now, this is a little off topic, but it has to do with refractory asthma, so I'm sure you've given it a lot of thought too. But there's the other big city in Pennsylvania and in several other cities around the country, and we heard last week from one of them, are sort of blindly in refractory asthma burning the muscle in the large airways, and we, for the life of us, can't understand why that would work.
I can't either.
But we respect your thoughts on it, and I'm sure you've thought about it.
I've thought about it a lot, and certainly I've been approached numerous times by the company to see if I wouldn't do bronchothermoplasty in my severe asthmatics, and I basically won't. I don't think it's ready for prime time yet. If people make a decision that they want to do it, I think it's okay at an academic center if you're going to have everybody protocolized and characterized and eventually be able to come up with, if there is a group that gets better, who are those people that get better. But the data are weak at best. With some improvement in asthma quality of life, depending upon how you count exacerbations, the exacerbations actually don't get better if you include the exacerbations after the procedure. They only get better if you exclude those. They keep touting this wonderful safety data that, a year now, 5 years down, the procedure is safe, but they don't tell you whether it's still working. There's just been so many, marketing ploys that have been used by this company. I don't trust them. I really don't.
That was a lot of our gut feeling.
Yeah, they're just sort of shysters. But anyway.
So don't buy a thermoplasty set yet, Steve.
No, we weren't thinking of investing.
And you know what? I think that their data even to say that the whole thermoplasty is working because it's burning out smooth muscle. This is based on one dog study, and it's a dog, and one thoracotomy study where they removed a lobe from patients that had lung cancer and basically had done thermoplasty on that section before it got pulled out. Again, in people with lung cancer, so there's no hypertrophied, hyperplastic smooth muscle. It's the wrong model, and it was in 3 people. So, those are the data.
Well, Matt?
I was just going to go back to your severe eosinophilic asthma patients. How far, I'm curious, and this will be relevant to our case we're going to present, you push that workup? You obviously do at least an ANCA limited room workup, and then the lung biopsy. Do you ever, how far do you push the rhematologic workup? Do you do a bone marrow biopsy? Do you do a joint biopsy?
The bone marrow biopsies I don't feel quite as strongly about. If you think you've got a hypereosinophilic syndrome, then I think you need to do the bone marrow biopsy. If you've got this prominent end organ eosinophilia, I think it's that end organ and or multiple end organs that are driving it, not a bone marrow problem. And so I tend not to do as many of those. But yeah, they get the the mega buck routine workup on rheumatologic endpoints, et cetera.
You know, I'm just going to mention, since I think it started in this city, our colleague Mike Malarkey over at Virginia Mason.
Yeah, was the methotrexate guy.
You
Yep.
know, really did some very nice studies,
Absolutely.
which for the most part were replicated around the world, except for one study at National Jewish, which clearly showed, and I didn't believe that study out of National Jewish, that methotrexate clearly was a steroid-sparing agent, and to this day I believe a lot safer than pushing long-term corticosteroids.
Mm-hmm.
And with much less science than you presented today, just clinical empiricism, occasionally still use that, and it'll be relevant to the case that we're about to present as well.
No, I think it's fascinating to look back at Malarkey's data. I really do, because you sort of say, that was done again on all-comers asthma. There's no reason that Immuran should work on all-comers asthma. It's going to be a select group that's going to, and yet he was able to show that methotrexate in a large group of unselected severe asthmatics had an effect. So I think there's a lot of overlap there, actually.
Well, let's take a break and we have the case. As many people who can stay, please do, especially on the line as well.
She thought she had asthma. Remarkable, she had a working night. Is it remarkable she had a throat biopsy and work up matter of every 10% history. Strange, yeah, just dyspnea.
Thanks for coming all the way up here.
I might send out an email later, but there's a new coding system.
I'm getting really senile. I'm getting really senile.
Well, actually, I recognize it as an 85% increase.
Oh, no. I need the anti-Alzheimer drugs up there.
Dr. Ray, second and third hour. Total was 300% increase. I was really grouped that.
So how's it going? And then the research coming
Feedback in terms of how much work is stress. The old code is based on right. The old code is based on a right reaction.
It's just another cell.
I was like,
Read some fellows
Strong arms. Yeah, they often need to be strong arms.
Sorry,
But smell. It does have a smell. There might be.
It's another time you gotta worry about it.
You know, they used to use it to rub on your jaw.
after an hour, it's cardio.
Do you want me to take some journals to my computers so you don't run enough? I was going to say, I can give you speaking here, Jen.
Just write their names down so I can tell the secretary not to mail.
But there weren't any left.
I had a good time. To your house.
So I'll write their names down. I think so. He's going to try. Did you get one already?
Right and left.
I'll just save you a postage.
We had pre-approved first.
Yeah, that's pretty good. We're trying to get around this mortgage. I can see what you signed.
It sounds like areas.
Yeah, all right. Give me some. Thinking that's my next file. I don't know whether I'm going to have it.
He carries that out.
Other than that, everything's taken care of. Pretty good.
I think he's got nothing.
Yeah, I was going to see him tomorrow. So,
I want to snack with that.
unfortunately, I got to go back to work sometime.
The wheel on it. So the seat basically out of nowhere. 20 years ago.
Don't hold that against me.
I'm not.
I can't remember yesterday.
I can't either, so I wouldn't expect you to do it. I did do that. Anyway. Oh, yeah, it was the worst. We go way back. Just out of the law. I like me as anything.
So he was basically, sending us
You're basically.
No, I remember.
and I thought, well, before I respond,
Something I was
Cheating is free.
free, so I want to make sure.
It's chocolate.
Sure. Well, if you text me again,
Yeah.
well, they have 3 months of these. Here and there. I was going to say, what I want to do is let me look at it for a while and go back and ideas. I always for like an hour. I like to have my questions before we sit down and talk about it.
extensive.
Like save some money. I mean, you don't yeah, let's give her something. I'll respond to him. You have to go. How many of you have 5 on Saturday. Yeah. Say thanks for I really enjoy it.
All right, thanks. Just bring it to pretty much. Okay.
I'm curious to know how much can a hit
I mean, when they that would fix the problem.
I just think about what nasty consequences with chloroquine therapy. I think we're way too tolerant of what happens in a prednisone world. It's familiarity. That's it.
You brought your own bag.
Where are you? Set up on my. You would give it a yeah, I'll be able to sure. You're in this all along.
Am I going to get a parking ticket if I don't push meter? The adult onset?
Hey, let's go ahead and reconvene. Everyone. Hey, can I get your attention? Let's sit down and present a case.
She's still coughing.
Good, so yeah, I have a case to present that I think will build on what we already started talking about this morning, and sort of severe persistent asthma. And this is a gentleman I met back in August or July or so of this year. So just a basic presentation. So chief complaint when he came to us, he was referred from down in Olympia, was persistent wheezing and chest tightness. His history, so he actually has had asthma since childhood. predominantly wheezing with URIs, with a lot of pollen exposure. This really resolved, though, in his teenage years at 15. Kind of came back in his mid-30s. He was living down in Sacramento at the time. And there he had seen an allergist. We didn't have any of these records, but was definitely sensitized to a number of pollens. Unclear to what extent that was sort of driving his asthma, though. He had come up to Seattle and was better in a new environment. Again, until about 20 years later, at 54, his asthma symptoms returned. So again, his symptoms were largely wheezing, chest tightness, cough. At that age, he had been started on initially just low-dose inhaled corticosteroid, and this over the sort of 5 years between age 54 and when we met him, had ramped up to Advair and Singulair. So in December of 2011, a little while before we met him, things worsened. There was no clear precipitant, but all of a sudden he had had an exacerbation. He was put onto prednisone and really never came off. So for the intervening 7 months or so, was on fairly high doses, anywhere from 40 to 120 milligrams daily. Anytime they had tried to decrease that, his symptoms would flare. So as long as he was on the prednisone, he was fairly asymptomatic, but he was becoming increasingly cushingoid. He'd gained 30 pounds, and so he was referred up to us. This is what he looked like as kind of a low-resolution photo, but just to show sort of the cushingoid appearance. And I have another photo down the road that'll show a more normal appearance for him. This was in August. His initial spirometry I have here. So it kind of, and then the numbers to go along with it. Looked fairly restrictive, sort of a mixed obstructive. Restrictive is FEV1, 55%, FVC 61, and not much of a bronchodilator response in the office there. So the first thing when we met him in August, the question, and this is sort of what we were talking about with the case in the presentation earlier, was, well, what's the differential, and do you need to really expand your differential beyond asthma here? So, obviously the asthma phenotypes, as mentioned, and or endotypes, and where he may fit in that. Thinking about, this is just sort of how I categorize it, and I'm certainly curious to get any input on this, but sort of the asthma plus diseases is how we always talk about it in residency. So your ABPA, your Churg-Strauss, your other vasculitic disorders, and then sort of all of the mimickers of asthma. So your various interstitial pneumonias, your exposures to inorganic dust, hypersensitivity, pneumonitis, and things of that sort. So in this gentleman, we sort of looked, at least for a limited set of these, and didn't find much. So the workup that I always think about when I see a patient like this is, well, certainly you need to image their chest. So we ended up getting high-resolution CT, plus minus sinus imaging if they have symptoms. Obviously, full PFTs in particular for a DLCO, and then at least a limited lab workup. So looking for eosinophilia, looking at the IgE level, looking for ABPA, looking for an ANCA. And then, as clinically relevant, you can certainly broaden this a fair bit, an extensive rheumatologic workup, an immunologic workup as relevant. Those are the labs I always kind of keep on my list of things to consider.
Let me interrupt you there for a second. I just want to, that pattern of having childhood asthma going into remission and then having severe adult asthma is very typical. And I'm wondering where you would place that in your endotype, what you would think this disease is before you know the answer to these questions.
I would obviously think it's a complicated disease. It's not one that's just continued to be an extrinsic allergic asthmatic. It's become something else. It's morphed. I think in most of these cases it has a Th2 core, but it has other things that have evolved around it. So again, in the spectrum of all those atypical asthmas or whatever that you put up. And again, we want as clinicians to put people in little diagnostic boxes. They don't fit in diagnostic boxes all the time. There's this spectrum. And I fully believe, rightly or wrongly, that Churg-Strauss is probably that very extreme end. My asthmatic granulomatosis perhaps a little further in, and then probably aspirin-exacerbated respiratory disease, adult onset eosinophilic asthma is sort of here, but they're all part of the same spectrum. So, where this guy's going to fall on that particular line, I don't think we know.
I'm sorry, in the history I may have missed it. What did he do occupationally as an adult?
So I'll come to that. He, no significant exposures. He's basically, his wife works in a hospital. He works as actually, do you recall exactly, it's a desk job of some sort. But it's nothing.
Actually, don't know my patient, but I can't remember.
We've gone through an occupational history, and there were no significant exposures.
One comment on the sinus CT. You said you do a sinus CT if there were symptoms. I would actually encourage you to do sinus CTs even if there's not symptoms. In these types of patients, you'll be amazed. They don't complain of acute sinusitis sort of symptoms. Often they'll say, oh yeah, I have some drainage down the back of my throat, but I kind of ignore that. You do a sinus CT and they're like completely obliterated.
I totally agree. We have a mini cat in the office. Did we do it on him? But
we got one.
Yeah, I mean, it is very helpful.
Yeah, even with very minimal symptoms.
Okay. So we sort of pursued some of this with him. So his workup, so we took a fairly extensive history, a review of systems, looking for exposures, looking for other things of a rheumatic spectrum, and really didn't find that. He had an outside or at another center, high resolution chest CT. I don't have any images for you, but it was read as entirely normal. We got a sinus CT in the office that was normal. We repeated skin testing, or he'd had it actually before he came to us, and it was pretty pan-allergic to the local allergens. We repeated aspergillus and all molds; those were negative. His IgE was high, but not through the roof. And then a fairly normal, basic lab workup. We're getting a little bit more of a rheumatologic workup now that's not back yet.
But really comment again on the CBC, because I'm guessing the CBC was done when he was on 40 milligrams of prednisone. So all bets are off on what the eosinophils look like in that.
And that's sort of what prompted me early to ask, when do you go searching further? When do you try to get tissue to look for eosinophilic disease? Because I believe that he probably does have it, and that you don't see it in the peripheral blood. But that's what we had with him. So as opposed to finding something to sort of lead us down one path or another, we were left with a relatively negative workup, but still, on high. Let's see. So, we got a full set of PFTs, which sort of confirmed a restrictive component to his disease. And then I always have a little trouble interpreting this, but the DLCO, so uncorrected, low. When they correct for the alveolar ventilation or the alveolar volume, I guess, it's read as normal or above normal. Suggesting, again, not really an interstitial process.
Matt, what was his BMI before the steroids? Was he non-obese?
He was overweight but not obese. I think his BMI was like 28, 29, that range.
Let's go back to the PFTs, because we see so many people with severe asthma, even not such severe asthma, whose pattern is restrictive. We keep calling it an obstructive disease and calling it asthma. And I ask Steve this all the time because he's very good at pulmonary function and I'm not. And I'm always dissatisfied with the explanation, not that he's not a good explainer, but I don't understand the physiology.
Well, and I struggle, Steve, maybe we should, with calling someone with pure restrictive disease asthma. Now, not that I think it can't occur in an obese patient, etc., but I think without seeing a age-adjusted reduction in FEV1 to FEC, and somewhere along the line of either a bronchial hyperresponsiveness or a bronchodilator response, I struggle to call that asthma in the general terms. So I don't know.
I always say, well, at least from attorney activity, there's a very small subset that have restrictive that with bronchodilator or with steroids or whatever, they increase in that maybe real reversibility.
I'm not convinced.
Well, that's good, because I'm not sure I've ever seen it, that convincingly, but that in general we still have a question mark unless we have some.
And I think you've got, these patients that have this pseudo-restrictive or restrictive process or whatever, I think oftentimes you see it in obese patients. Oftentimes you see it in someone who you're concerned about vocal cord dysfunction. I get concerned if you see a bronchodilator response, but you also see this increase in FVC that's out of proportion perhaps even to the FEV1, even though that FEV1 crosses the 12% threshold. They took a bigger breath, you know? But does that really mean that they had a bronchodilator response?
And sometimes it's the quality of the technician. And
Yes,
so we always try to
absolutely.
refer
Did
to
they
a
really
real,
push them?
real PFT.
Yeah, yeah. No, I think that's important.
Do you have prior pulmonary function tests when you was in Sacramento? Just no.
You mean like lung volume?
I was just curious what the progression was when he was.
Yeah, we didn't have much in the way of records. I forget who the referring doctor was, but we had one past spirometry from, when he was already on systemic steroids, and it was similar in terms of the FEV1, FVC. We didn't go searching for those records. Maybe we should from California.
And were these done plethysmographically or with helium dilution?
I'm not sure.
I almost think they might have been helium dilution.
How good the PFTs were from Sacramento.
Well, no, just were these helium dilution or plethysmographic lung volumes? And if you have a lot of air trapping, the helium dilution isn't necessarily the best way to do it because you won't get even distribution of the helium. And it almost makes you wonder whether, in this case, especially since corrected for alveolar volume, you actually get a high DLCO, that your total lung capacity is not completely accurately reflecting the alveolar volume.
Right. Matt, this guy never had immunotherapy and no omalizumab.
He never had either of those previously.
Not yet.
Yeah. So the other question
was,
what to do with this guy?
It's a miracle.
So we empirically, without tissue or anything of the sort, started cyclosporin at a pretty high dose.
And treating what?
That's the question.
Well, I would have made that decision, so
yeah,
I'll respond to that. And this is clinically empiric medicine. Going all the way back to strongly believing that methotrexate works in this disease, and cyclosporin is a very effective T-cell therapy. Over my career, without tissue and just open practice of medicine, when I see people like this, and people who have very severe chronic rhinosinusitis, and chronically are getting treated with antibiotics and steroids and not doing well, I think this is an autoimmune disease. Mm-hmm. And I'll use methotrexate and cyclosporin, and this is not science, this is just practice of medicine. These people do beautifully, as he has. And it's a much safer therapy than 120 milligrams of prednisone.
Oh, absolutely.
And,
So it's a steroid sparing.
Steroid sparing.
This is an academic medical center, so to make those kind of egregious comments But in selected cases, I probably have about 10 people in my practice who I have either on methotrexate or cyclosporin for a disease like this. What I would still probably call adult onset intrinsic. Even though he's atopic, I don't think that's a driving force in his disease at all. So anyway, that's the best decision making I can give you as to how this happened.
Mm-hmm. Yeah, but I mean, I think that's what we all tend to do. We try to get our patients better, and we try to use our brains to do that. I would maybe suggest in the future considering actually doing a lung biopsy on some of these folks, even with the normal CT scan, because all of my patients, one thing I didn't mention, all of them have normal CT scans. Even with those normal CT scans, you still see these fairly profound changes. And again, the reason that I'm asking this is mostly self-serving, but I think it's important for this disease to be described outside of Pittsburgh, because if it's only, all my patients in Pittsburgh, they're just going to go, well, these are your patients in Pittsburgh. But, I think it needs to be looked for other places.
What do we have objective in this guy right now?
Objective?
Yeah, the diagnosis of asthma.
Yeah, not a lot. We have the PFTs, which, as we discussed, are largely restrictive, and then we have the symptoms that were definitely responsive to steroids.
And that's the key too. They do respond to steroids, but boy, it's enormous.
It's not like one of these questions.
Right.
So has he lost weight?
Yeah, so here's what happened. So on that alone, he, over like the course of a month, came down. We first were tapering 10, then 5, then 1, with a 9, at which point we had gotten approval for Xolair, so started that on top of it, and over another month came entirely off of prednisone. So at this point, he's on Advair, he's still on montelukast, he's on cyclosporin, Xolair, fexofenadine, and albuterol as needed, not using the albuterol. His PFT is, this is like 2-3 months later, didn't really change. So similar FEV1 FVC.
Did weight come down?
40 pounds or so, right?
Yeah, so, and then picture of him, he lost 25, 30 pounds back to his normal weight, effectively. The problem we've run into, and this is just less than a week ago or so, is that he has had a rise in his creatinine, he has had a slight rise in his bilirubin. So we're dealing with that. We've stopped his ARB and we decreased the cyclosporin dose. We got labs yesterday, but we haven't seen them yet. And that's kind of where we are.
What were his meds before he started the cyclosporin? Like when he first came in to be seen?
Prednisone 60.
Just 60 the prednisone?
Yeah, he's
So
on
it wasn't on Advair.
He's on Healsterin.
No, he was on he was on Advair, he was on Singular, he was on all of those minus the cyclosporin and the Xolair, and in place of that was on high dose prednisone. So.
Did you have any concerns that the montelukast might have been playing a role?
Yeah, no, it's a good thought. I mean, montelukast has been implicated in a number of eosinophilic disorders, and we didn't stop it. We didn't see eosinophilia in him, but again, we could have missed that from the steroids. And he'd been on that for a couple of years. It's a good thought. It's probably not doing anything for him, or may not be.
I was actually, with Bill sitting over here, I hate to say this, but when Art Vey said 50% of people respond to montelukast before, I'd put that number at about 20%.
So you've got both Sally and Bill.
I'd say 35%. That's right in the middle.
Diplomacy.
But equally concerning, I mean, it has been implicated in driving eosinophilic disorders.
Absolutely.
Probably would be worth. I mean, it'll be tough now that he's on other treatment, but.
And despite the fact that the literature says, it's just unmasking Sturge-Strauss, I don't think that's the case. I actually really think it causes.
It's clearly been implicated in causing and other eosinophilic infiltrative disorders. I've seen reports of it causing liver eosinophilic disorders and others. So
it's not just unmasking.
Yeah. So we should probably stop that. That's a very good point.
The timing of the anti-G, why didn't you initiate that earlier?
You got to get
approval.
Yeah. That's just, he came to us without it having been considered at all, so we applied the first day we saw him. But getting the approval process takes time.
Mm-hmm. With tapering of his prednisone, have you been able to detect the eosinophils in his blood now?
Well, we just got blood yesterday, so I haven't seen it.
Okay.
So we'll see.
Yeah.
And did somebody try anticholinergics along the way?
I don't think so.
You want my thoughts on it?
Yeah, that'd be great.
That'd be a good thought.
Do you believe there's the trial data?
Yeah, I believe the trial data. We said 900 people, and they had to actually have 2 studies to even show differences. I think it has a bronchodilator effect, for sure. I think the effect on exacerbations, if you had controlled appropriately for their 3 primary outcomes, which they didn't, it wouldn't have been a significant decrease in exacerbations. And it's a 20% decrease in exacerbations. I'm not even sure I know what that really means. And symptoms didn't get better. Symptoms, quality of life, none of that got better. So, it makes us feel better because the FEV1 looks a little bit better.
But you, in terms of endotype, phenotype, you don't think there's a subset that has a dramatic response?
It's not been well enough studied to know that yet. I have probably used tiotropium in 90% of the patients that I have seen. Occasionally I'll have people go, yeah, I feel a little bit better on that, but it's not a life changer.
So I'm really fascinated by the use of cyclosporin, and one could argue that his absolute dose might have been high, but his body weight was also high, so his dosing range wasn't really that high up there. And I'm curious to see how his treatment response and his creatinine follow with the decrease in therapy. But I had a question about lung biopsies. So This is kind of a naive question. Is it usually bronchoscopically or transthoracic?
No, transthoracic. So this is a video-assisted thoracoscopic biopsy. So it's not like the old thoracotomies where you had to break ribs and stuff. It's an endoscopic sort of approach.
And are pulmonologists keen to do that if I were to send
No,
patients?
it's a some pulmonologists will do it, but I wouldn't have a pulmonologist do it. I would have a thoracic surgeon do it.
Yeah. In patients like this, they get clinically better. This guy's gotten dramatically clinically better, but their pulmonary function doesn't change. And often that happens when you put people on Xolair as well. They clinically get better. You can get their steroids lowered, but you see very small changes in PFTs. So why do these people feel clinically better?
Well, I don't know. The patients that I've been treating actually do see an improvement in FEV1, and it's not like they return to baseline, but they're 10 to 20 percentage points better on the immunosuppressive therapy. And I think some of it actually may be just you're improving small airway disease. And the small airway disease isn't quite so much reflected in the large airway changes in FEV1, but they are able to move air back and forth in their lungs better than they could before, and so they feel better.
Have you any thoughts on roflumilast? Have you had any benefit in severe asthma?
You know, I haven't really used roflumilast very much, so I don't feel comfortable commenting.
How about your omalizumab experience?
Well, my omalizumab experience is fairly lousy, but again, I see obviously the most severe people. And I think by the time they're come to see me, the concept that an anti-IgE is going to cure them is pretty small. And I would say maybe 20% get better with it, and even then the response is not hugely life-changing.
So how about the difference between the patients you see and the patients whose life has changed in a positive way from moderate high-dose inhaled steroid combined with long-acting beta agonists? Is there a
I think there's a difference. Yeah, I do
there's a
think
niche
there's
between the two that would be great for omalizumab.
Absolutely. I think the moderately severe patients are the ones that benefit most from omalizumab.
Of new therapies coming out, what do you holds the most excitement for you?
I guess having had the Pittsburgh experience and dealing with blocking IL-4 and IL-13 together, there are a few companies that are still developing an IL-4, IL-13 approach. That's probably the one that I'm most excited about. I think the anti-IL-5s are going to reduce exacerbations, but patients aren't going to feel better. And if the patient doesn't feel better, I think if you've got $100 a month copay or whatever it is, and you change your exacerbations from 3 to 2 a year, patients are going to go, is it worth the $1,200? And well, if you would go to the emergency room, yes, it would be worth that $1,200, I guess. But I think patients are not going to sort of stick with it in many cases. And so anti-IL-5s, although they are teaching us a lot, I'm not sure will be blockbuster.
Can I ask about that? Just because I've reviewed the literature on anti-IL-5 for hypereosinophilic and Church-Strauss, and we're starting a kit on it for hypereosinophilic, and it's markedly, it's great. It's like a miracle for both of those conditions. Why in seriously eosinophilic asthma you're not seeing?
Because it's not a hypereosinophilic syndrome. It's more complicated than a hypereosinophilic syndrome. I think hypereosinophilic syndromes are really a primary eosinophilic disorder, and if you take IL-5 out of the equation, you're having a huge impact on the disease.
If you treat those asthmatics with anti-IL-5, do the eosinophils go away?
Yes. Well, yes. I mean, that's what anti-IL-5 does.
But that's been shown pathologically, or?
In sputum and in endomarginal biopsies, they don't really go away with the mepolizumab, but they're reduced substantially. In the blood, nothing. No, we've had patients in the Harvard Lancet paper anti-IL-5 study, and I had 4 people on drug, 1 on placebo, because it was a 3 to 1 ratio of drug to placebo. I had one person out of the 4 that were on drugs that said, wow, this is the greatest thing I've ever had. When can I get this stuff? And the other 3, one dropped out early because she didn't see any efficacy. The other person went through the whole clinical trial and didn't do anything. Lung function, symptoms, exacerbations, nothing. And then the 4th patient was just kind of flat. So again, there may be a subset of even eosinophilic asthma that will go, oh, this is really cool. But then there's going to be a bunch that haven't. And interestingly, the one woman that was in that study was on high-dose anti-IL-5, did nothing for her. I did a biopsy on her. She does have this sort of asthmatic granulomatous disease, and she got put on azathioprine. And this is a woman who literally her lung function was in the 45 to 55% range all the time. She's up to 90% predicted on azathioprine now. With prednisone doses, she was 20 milligrams to 30 milligrams a day every day. She's down to 5 milligrams a day.
As I said, I have a number of people on either cyclosporin or methotrexate, and I don't have experience with other immunosuppressives. So how do you select which ones and based on what biologic property of the drug?
And I guess I started with azathioprine because I thought there was some overlap with immunologic disease and with hypersensitivity pneumonitis, and I had some experience using azathioprine in those diseases. And I think it's a little less toxic than Cytoxan. Perhaps a little less toxic than cyclosporin, but they're probably pretty close because you clearly have LFT issues with Imuran too. But that's the drug that I've seen the best responses to. I've seen a few people respond to mycophenolate, and then I've had one person that couldn't tolerate azathioprine, couldn't tolerate mycophenolate, who I actually have on methotrexate, couldn't tolerate the oral methotrexate, but is getting injections of methotrexate and is actually doing quite well on the injection.
The reason I usually don't go first to methotrexate is if you use it as pulse therapy, the response is a lot slower than if you're giving something every day. And this guy needed to get better right away.
Yeah.
When we first saw him, I hadn't seen anybody since I was a house officer who was this cushianoid.
I see them all the time. I actually have 5 people in my clinic that have bowel ruptures from chronic steroid use. And I think to somebody's point, we sort of take steroids for granted as clinicians. Oh, prednisone, just put you on prednisone. It's a benign drug. It's not a benign drug.
And it adds up over.
Oh, it's a horrible drug.
This guy was at one point, I don't know how long he was on 120, but...
that's intolerable. That a physician could put somebody on 120 milligrams a day of prednisone. You try taking that.
Well, I have a question about, just clinically in the front lines trying to decide what to do, and I get technically severe by spirometry criteria that's not reversible, but sort of behaving like COPD, even though previously responded well at least 15, 20 years ago. FEV1's still like in the 40% range or even lower.
And no
not particularly, although they get exacerbations in response, so they're kind of like COPD patients, and that's how I treat them. And their DLCO is normal.
Right.
So I don't know. Do all of the? I assume when I refer to pulmonary, in at least on the east side around here, they rarely get chest CT. So I'm often the one that gets that thinks to get that. Because they think, well, they're stable and this is fine, and it always makes me nervous not to have that information. But I was wondering if you think that that's necessary or a reasonable approach.
Well, there is going to be a statement that comes out hopefully in the next year on our ATS-ERS task force on severe asthma, where we actually did the grade recommendations for things like exhaled NO and sputum eosinophils, and didn't do cyclosporin but did methotrexate. Anyway, we did one on CT scanning and whether CT scanning was really worthwhile.
Right.
And,
it's a struggle.
And there's very little data, one way or another, to know, in an objective manner, is it really helping? But I think our recommendation was a low-level recommendation for doing CT scans based on poor quality evidence that if you had a somewhat atypical presentation of a severe asthma patient, that those were the patients that probably deserved to have a CT scan. But that was really consensus opinion, not, you know.
Right, but at least there's got to be something that's like, because I always talk about the radiation, but it and the expense, but it seems to me, before just dooming them to a life of you know, anaerobic existence, that it would be nice to have that information.
Yeah.
Well, thank you very much.
Thank you.
Enjoyable
It was
morning.
fun. Absolutely. It was a lot of fun. And good case. And let me know what his CBC shows.
Yeah. Certainly, if there's anything in the eosinophils,
Take care.
at minimum, stop the singular, maybe pursue.
You got to get his renal function corrected.
Yeah, you got to get this.